Global Health at the UIC School of Public Health. And we are happy to welcome you all to our Global Speaker Series. And for our first Global Speaker of the year, of the academic year, we have Dr. Jonah Musa. So Dr. Musa is a gynecologist by training, obstetrician and gynecologist, and he is a professor of obstetrics and gynecology at the University of Jos in Nigeria. He graduated from Northwestern University with a Master of Science and a PhD in health sciences in the integrated program. So Jonah is a triple threat, master's, MBBS, and PhD. And he is an extremely productive researcher and scientist. Jonah has over 40 publications. And I had the opportunity to meet Dr. Musa through his work at Northwestern, where he has been studying cervical cancer with Dr. Li Fangho and her team. And through all of his research, Dr. Musa he's been awarded the very prestigious K43 Emerging Global Leader Grant from the National Institutes of Health, where he will be studying the vaginal microbiome in cervical intraepithelial neoplasia and cancer. So Dr. Musa advises many students. He teaches at the medical school. He's a productive researcher. I know that he has been extremely productive throughout the COVID pandemic, and we hope to see him again in Chicago sometime soon. So we're very much looking forward to your presentation, Dr. Musa, and I will turn it over to you. To the audience, please type your questions in the chat box, and then we'll take those at the end. Thank you.
Thank you very much, Supriya, and I want to thank you and all the faculty at the School of Public Health at UIC for giving me the honor and opportunity to share my thoughts on this very important women's health problem, cervical cancer. And specifically, we are going to be looking at this problem in the perspective of low and middle income countries. And I'll be highlighting the need for the global community, health community, to invest in prevention and research in order for us to control this disease. And a few of my objectives, I'll be giving us a brief global burden of cervical cancer and its relationship with HIV prevalence, particularly as it concerns sub-Saharan Africa. And then I will look at the need for research and prevention, evidence-based interventions for prevention. And then I'll briefly mention the economic benefits for us if we achieve prevention. And then I'll highlight one of our current global collaborative research project, which Supriya and other faculty in Chicago are mentoring and collaborating with me. So just to start off, this is the cervix, all right? And if you look at the body of the uterus here, the lowermost part of it is the cervix. And that is where we literally say the mouth of the womb. And this is the anatomical area that opens up during childbirthing process. And if you look at it here, this is the way a normal cervix looks like. So we have what we call the external os, the ectocervix. And as soon as a young woman starts to have sexual intercourse, this human papilloma virus, which is the DNA virus, infects the cervix. And when it infects the cervix, it doesn't announce itself. So it is possible that the immune system of the young woman could result in clearance of the virus. But if for whatever reason the virus persists in the cervical tissues, then it begins to cause cellular transformation. And if you look at it here, these areas, these whitish fleck areas, you know, this is transformation, this HPV transformation of a normal cervical epithelium. And this is entirely asymptomatic. So no woman will say she's experiencing symptoms of HPV infection. And that is why the issue of screening is very critical. If you don't go, if a woman doesn't go for screening, these lesions here will go undetected and it will progress to invasive cervical cancer. Just to show it in another way, this is the way normal cervix looks like. And then you have low-grade dysplasia. That is, the HPV virus has persisted and has started to transform the normal epithelium. By the time you get here, this is high grade, and you can see the density of the wideness here has increased. And then underlying it, you have blood vessels are beginning to grow. And at this point, this is already invasive cervical cancer. At this point, if it is not detected early and treated, the prognosis is already going down, going very low. And these are some horrible pictures, and this is what we see typically in low resource limited settings, where most women present with advanced cancer. You can see the whole of the cervix here has been invaded by cancer, and it is involving even the vagina. So that is briefly what the cervical cancer is. In terms of global estimates, and this was published in 2018, and the statistics haven't changed that much. So in 2018, over 570,000 new cases of cervical cancer occurs globally. Now, if we look at the age standardized incidence for low middle income countries, especially in sub-Saharan Africa, you will see that it is ranging between 27 to 80 per 100,000 women years, compared to richer countries in North America, Europe, or in Australia. You find out that even just on this map, there is a huge disparity. Now, if you come to risks of mortality, globally, 311,000 deaths are attributed to this cancer that same year. And if you look at it, the majority of women that die of this disease, again, are from the low and middle income countries of the world. Now, if you do a small math and you calculate what we call the mortality incident ratio for cervical cancer, given this particular data, you will come up with a mortality incident ratio of roughly 60%, meaning that this woman that will develop this cancer, the 570,000 cases that develop cancer, over or close to 60% of them will die within the first year of diagnosis. And majority of them are from the low and middle income countries of the world, particularly again in sub-Saharan Africa. Now coming to Nigeria, where I am, and West Africa, this bars just tells us the distribution of new cases of cervical cancer annually. The statistics we have for Nigeria right now is that we have close to 15,000 new cases of cervical cancer every year. And if you look at these bars, it cuts across ages from 25 down to 75 years. And if you look at it, the proportion of the cases in Nigeria is actually like 2/3 of the cases in West Africa. And this gives us a lot of worries about the high burden of this cancer in Nigeria alone. Now compare what we are doing in Nigeria, West Africa to the rest of the world. If you look at the incidence, the annual incidence by age group, it has been going down. So the rest of the world has made so much progress, but West Africa, Nigeria, and most of sub-Saharan Africa and other lower middle income countries, they are continuing to have sustained increase in incidence of this preventable cancer. So as I mentioned, one interesting thing is that we've seen a correlation between regions of high HIV burden with also high incidence of cervical cancer. So this again shows us that there is a strong relationship between HIV prevalence and the burden of cervical cancer around the world. So there was a systematic analysis of data, mainly in Southern African countries. And this was published just in 2020, and it tells us that the pooled relative risks of developing cervical cancer was 6.07. That is, women who have HIV are 6 times more at risk of developing cervical cancer compared to those who are HIV negative. And this is particularly so for areas where the women don't have access to effective antiretroviral therapy with poor immune suppression, poor immune recovery or virological suppression. So this is one review article that has summarized some of the factors that are responsible for the high burden in these countries. One of it is HIV infection, as we have seen. The other one is lack of organized cervical cancer screening programs. And there's poor coverage, even when screening is available. And then the issue of illiteracy, weak healthcare system and coordination for screening, and then poor vaccination coverage. There are still a lot of countries in fact, majority of countries in sub-Saharan Africa and other lower middle income countries don't have a national program for human papilloma virus vaccination. So these are some of the factors that are responsible for this high burden. So the take home for this is that if we look at the data, we'll find out that 9 in 10 cervical cancer deaths worldwide occur in low and middle income countries. And women who are living with HIV are 6 times as likely to develop cervical cancer compared to those who are HIV negative. So one of my objectives is to justify the need for us to invest in research and prevention. And I will show us data to support this. But I have just summarized here that most countries in lower middle income countries, because of poor treatment infrastructures, late presentation, and the high mortality associated with this disease, the best way is for us to invest in research and prevention, for us to improve the outcomes of patients with this condition. So this is just one study that we did here in Jos, Nigeria, and we have other related studies done in Kenya, Ghana, and other lower middle income countries, all pointing to the fact that cervical cancer survival is dismally low in lower middle income countries. So our data here shows that over 70% of new diagnoses of invasive cervical cancer were at advanced stages. And because of poor treatment facilities, if you put everything together and follow up these patients, less than 20% of them will survive beyond 2 years following diagnosis. This again shows us that the survival chances for patients with this cancer in resource-limited settings is very, very poor. And we need to begin to think about prevention rather than investing in treatment, which eventually will lead to poor outcome because we don't have even the facilities. In that same paper, we look at anemia as one of the risk factors for early mortality. And this is what we found, we categorize the packed cell volume on admission, and those who have anemia at presentation, you can see rapid decline in survival. And we also look at what we could offer for those who present in early stage, figure stage disease, where we have an opportunity to do local regional surgical control. And we look at that and we found out that those who were exposed to having modified radical hysterectomy for early disease, they have a mean, a median longer time of survival compared to those who did not have surgery. That is, they receive the conventional treatment without surgery. And we learned a lot of lessons following this, because prior to this evaluation, most of us, we make a diagnosis and then we refer patients to radiotherapy treatment units. So we decided to look at the data, and this was the lesson that we learned even from our own institution, and it has informed us to review our SOPs for managing these patients. So the main findings, or the meaning of these findings from this paper, showed us that advanced stage disease and baseline anemia were independently associated with higher death rates. And then the issue of referrals, most of the time in lower middle income countries, we may refer patients for additional treatment elsewhere, but we don't really follow up to find out whether they do complete the treatment. In that cohort that I just shared, only 11% of women that we referred them to receive specialized treatment elsewhere ever reach that destination. So we concluded that if we diagnose patients with early stage cervical cancer, we should offer them early opportunity for local regional surgical control, because if we do that, it can really improve their survival. Again, highlighting the need for screening, which will give us an opportunity for early detection and treatment of precancer. Now, this is where I am practicing. This is our hospital, and we have a cervical cancer screening unit. Not organized, it's mainly an opportunistic screening unit. And this is how women come in. We take risk factors, and then we enter into the computers. This is the room where we take the screening. And then, excuse me, the slide is not moving. It's just, sorry. Okay. Oh. The screen is not moving. Let me see, please. Okay. Okay, so this is the remaining setup, where we have colposcopies, and then we have treatment facilities with LEAP. And the data we gathered from that screening unit over a 10-year data, we analyzed looking at HIV status, age at cervical cancer screening. And Supriya is one of the co-authors in this paper. So the message I want to share with us here is that the median age at first cervical cancer screening in this cohort was 37 years, which is very late. In the US, most women, because they have organized cervical cancer screening, they start to invite them for screening at 21 years. The French and Australian cohort start at 25 years. And there are other settings that have data to support starting at 30 years. But in Nigeria, this is the median age. And the message we want to share here is that women initiate screening quite late. Now, looking at HIV status and age at first screening, again, our data showed that those women who are HIV positive, they tend to start screening at a relatively younger age compared to those who are HIV negative, partly because they are aware of the risks, and then they tend to have more contact with the healthcare system. And then the issue of recommendation by the providers will really lead them to initiate screening at a younger age compared to those who are HIV negative. And we also try to look at the age at first screening and the probability of having higher grade cervical lesion. This is not perfect correlation, but it just tells us that when women initiate screening much later in life, there's a higher probability that the result will show a higher grade lesion compared to those who commence at an earlier age. So I've already talked about some of the summaries of this. We also found out that women who have received education up to 12 years of education, that is those who completed 7 to 12 years of education, they tend to start cervical cancer screening much earlier compared to those who have received lesser years of education. Now, the implication of women starting to screen at 37 years, when we look at data from a huge cervical cancer screening program in Zambia, we found out that HIV-infected women, the median age at diagnosis of invasive cervical cancer was 35 years. So if you look at our women starting to screen at 37 years, they will have missed so much opportunity to detect precancer and effective treatment. So this has been a big concern for us. For example, I have a patient right now that is just 32 years and she already has invasive cancer, telling us again that we need to make an investment to screen this woman much earlier so that they can benefit from screening treatment of precancer before they develop invasive cervical cancer. So we also look at one of our systematic review studies looking at the role of cervical cancer education and healthcare providers in cervical cancer screening. So since the discovery of the Papanicolaou smear in the 1950s by George Nicholas Papanicolaou, who did his legendary work showing that just examining a cervical smear under the microscope could lead us to detecting precancerous changes in the cervical cells, which could be treated. But the question we ask here is that we have this effective intervention, health service intervention, but what can we do in order to improve the screening rates or the screening participation? And that was the motivation for this systematic review that was published in PLOS One in 2017. The major highlights of that very paper, it shows us that those who were exposed to theory-based cervical cancer education, they were 2.5 times more likely to initiate and complete cervical cancer screening compared to those who received didactic or non-theory-based cervical education. Now, we also look at the options of offering women self-sampling, and this is very critical in low and middle income countries where women may not overcome the barriers of accessing healthcare facilities, or due to religious or other barriers, some of them may want to take their samples in the comfort of their own rooms. So we found studies that offered women the option for self-sampling. And we found out that those women who were offered the option for self-sampling, particularly those who have not adhered to the screening recommendation, it increases their participation by 1.7 times. So what we learned from this is that Theory-based cervical cancer education rather than didactic lectures improves participation of women in cervical cancer screening, and that this intervention is even more impactful in communities with low literacy levels, where you understand the culture of the people, and then you design a theory-based cancer education package, and that has been shown to improve women participation in screening. And then offering opportunities for safe sample collection. And this is one of the implementation science questions that a lot of people are applying now. What can we do in terms of safe sampling, especially in hard to reach areas where women will be trained? They will collect these samples for HPV, and then they will send it. They can mail it to the healthcare facility, and the healthcare facility will now examine the sample, report, and then those who have abnormalities will now be invited and supported to receive further evaluation and treatment. And this option has proven to be quite cost-effective for women, especially in hard to reach areas. So briefly, some evidence for prevention. And in 2018, the Director General of the World Health Organization, launched an initiative. And this is one of the statements that he made, that one woman dies of cervical cancer every 2 minutes. Each one is a tragedy, and we can prevent it. And if we look at all the data, we know the natural history of cervical cancer. We know what causes it. We have an effective preventive vaccine, and we can screen and detect precancer. Yet, countless number of women are dying every day. So WHO launched this effective, this elimination initiative. So before I go on, what does elimination mean? It is defined as reducing the number of cervical cancer cases in each country to 4 or less per 100,000 women. And when this is achieved, cervical cancer will be said to be eliminated. Now, I have looked at most of the data across the globe, including US. No country has achieved elimination yet. But US, a lot of countries in Europe, Australia, they are on track towards elimination. So, and this is what the cost-effective strategies are. Through cost-effective evidence-based interventions, including human papillomavirus vaccination of girls, screening and treatment of precancerous lesions, and improving access to diagnosis and treatment of invasive cancer, we can eliminate cervical cancer as a public health problem and make it a disease of the past. Now, this is work in progress for many countries of the world. So this is what this HPV vaccine does. If we give human papillomavirus vaccination, it blocks the infection of young girls with the human papillomavirus in the cervix. And a lot of countries are making progress with that, but those in lower and middle income countries are still lagging behind in this intervention. The secondary level of prevention is early detection. And I've talked about just doing screening, pap smears. You can detect changes in the cervix, and you can easily administer treatment and block progression to invasive cancer. The third arm is that if we detect cervical cancer very early, as in this case, and you do proper locoregional tumor control with surgery, you can also achieve near cure in patients who have invasive cancer. So those are the effective interventions, and WHO have summarized them here. We call it the 90-70-90 target. That is 90% of young girls between the age of 9 and 15 years should receive at least one dose of effective human papillomavirus vaccination. And 70% of women should receive an effective cervical cancer screening by the age of 35 years and receive one more test before the age of 45 years. Now, this indicator that is given treatment, that is 90% of those who are screened here with abnormalities should be able to receive treatment. So the performance here is dependent on how many women that were able to screen in this particular target. So this is the 90-70-90 target by WHO, and member countries are supposed to work in order to achieve this. But as I mentioned, a lot of countries are still lagging behind in achieving this. I want to briefly highlight again the high disparity in prevention for looking at the 3 pillars for cervical cancer prevention or elimination. There is a high disparity between the lower middle income countries and the high income countries of the world. Now, these are the proportion of HPV vaccine in national immunization schedule. If you look at it in the high income program countries, they are nearing 90%. So they are getting close to the 90 target for this particular intervention. If you come to upper middle income, they are close to 60%. But when you come to lower middle and lower income countries, we are here around 20%. In fact, in Nigeria, where I'm speaking from now, we don't have a national program on immunization. Only few parents are able to afford this. If you go to Rwanda, they have made a lot of progress because of the political will in that country. And this is the summary of what I have just talked about. I don't want to go into it. Now, the other thing, the target, that is the 70 target, which has to do with cervical cancer screening program. In the high income countries, they are over 80%. If you come over here, we are down here to less than 40%. In Nigeria, the data we have showed that cervical cancer screening program are reaching just about 9% of women who are at risk. There are 53 million women that are at risk of developing cancer in Nigeria alone. And the cervical cancer screening coverage is reaching just about 8.7% of that population. High disparity. Now, if you look at the issue of treatment, if you look at cancer treatment centers between high income and low income countries all along, pathology services, cancer surgeries, chemotherapy, radiotherapy, you see where the low and middle income countries are, highlighting the high disparity in access to effective treatment between high income and lower and middle income countries. Now, I want to just highlight these projections so there was a modeling looking at the impact of human papillomavirus vaccination program and cervical cancer screening on cervical cancer elimination. They look at 78 lower middle income countries. And when they look at it, the prediction shows that when we achieve high HPV vaccination coverage of girls, it can lead to cervical cancer elimination in most LMIC's countries by the end of the century. And if you add it again with the cervical cancer screening program, we could achieve high yield. And these are some graphs that shows what will happen if we implement those effective strategies, human papilloma vaccination and screening. You will experience, countries will experience rapid decline in incidence. And by the time we are getting to 21, 20, in fact, even 21 or even 2080, this is where we will be. We will have already reached elimination. When they look at the data, the modeling data in those 78 lower middle income countries. And when you look at the life course approach, what this is telling us is that we should do or invest in primary prevention by HPV vaccination between 9 and 14 years. Because by 15 years, when young girls will start to have sexual intercourse, HPV infection will set in. And then by 30 years, if we have effectively vaccinated a lot of these girls, then we'll have less abnormalities with precancer when they begin to screen. And there will be lower incidence of invasive cervical cancer down the years. So countries of the world, the global health community needs to make advocacy and make sure that they support countries to invest in prevention at primary level, secondary level, as well as even tertiary level. So are there economic benefits for prevention of cervical cancer? And again, when we look at the prime modeling study, if we look at the cost effectiveness of this intervention, it shows that it makes the highest impact in the lower middle income countries of the world. For example, if you look at high income countries like US, the proportion of all prevented cancer is just about 5%. Proportion of all prevented deaths is 3.8%. But when you go to lower middle income countries where they have the highest burden, if we invest in prevention, you can look at the cost effectiveness. This is the proportion of cases prevented, 35.6%, 36.6% in deaths, and it goes down. So this tells us that those areas that have the highest burden, they are the ones that will have the more economic benefits in investing in prevention. And that is the message we have here. So WHO again have used a lot of data, and this is what they said, that by investing to meet the 90-70-90 target, an estimated 250,000 women will remain productive members of the society and adding an estimated $28 billion to the world's economy by 2050. Again, telling us we need to invest in prevention. And these are some summaries of advantages of preventing cervical cancer. It eliminates poverty. A lot of women, they drain their family resources because of this cancer. Good health and well-being, reducing premature mortality, ensuring universal access, gender equality, and reducing inequalities. And this just tells us the summary of the economic benefits here. So when we invest, we have more money to tackle other competing non-communicable diseases in our healthcare sector. It boosts our GDP because premature mortality and years of loss of life to productivity is cut off. So more women enjoys more productive life and they bring more money to the economy. Increased workforce participation, reduce healthcare expenditure. You know, a lot of women will become healthier, life expectancy will increase, and then there's increased earning capacity because if these women are healthy, they are involved in doing a lot of family chores, they can do a lot of work and add to the economy of their family. The last part of my presentation has to do with the vaginal microbiome in cervical intraepithelial neoplasia and cancer project that Supriya talked about. And she happened to be one of my strongest collaborator and mentor on this project. And this project is in its third year now. And we designed this project based on the natural history of cervical cancer. As I mentioned earlier, this is the way the normal cervix looks like. With the infection with the high-risk human papilloma virus, it begins to cause cellular transformation here, and then it progresses to high-grade lesions and then invasive cervical cancer. So what we have designed is to understand the factors that leads to HPV persistence or clearance. Because we have talked earlier that when the cervix of a young woman gets infected with the HPV virus, it comes in here and two things could happen. It either remains, that is persistence, and continues to multiply until it transforms the cervix into the invasive cancer phenotype, or as it comes in, something else may flush the virus out. And then you have cervical, a cervix that is free of HPV. So what we are doing in our study, and we are collecting specimens, and very soon we'll be shipping samples to UIC for more analysis. We are looking at the microbiome community state types. We're looking at BV scores. We're also collecting cervicovaginal lavage specimens for microbiome DNA sequencing. And we're also looking at pro-inflammatory cytokines and also the type of HPV that is prevalent in women who have a spectrum of either normal cervix, low grade, cervical intraepithelial changes, high grade, and invasive cervical cancer. So we are collecting epidemiologic data, and then these genomic data, including the inflammatory cytokines, and correlating it with these cervical cancer pathologies. And at the end of the day, we'll be able to have an understanding about the factors that can lead to either HPV persistence or clearance. So I won't go much into the specific aims. We have a cross-sectional aim, and then we also have a longitudinal aim. And we are enrolling patients with normal cervix, those with low grade changes, those with high grade changes, and then those who have invasive cancer changes. For the longitudinal aim, we are looking at those with low grade, and we are following them over time to see what happens to all those markers that we have talked about. So we have a very robust flow of the study, and then these are some of the summaries of what we have collected so far. And in the next 1 month or so, we'll be shipping this extracted microbiome DNA to UIC for subsequent analysis, as well as bioinformatics, cytokine access, and then the HPV genotyping also. So I want to end by telling us we should look out for upcoming publication from this data that we are doing. And as I mentioned, is one of my, it's my K award. And in conclusion, we know that cervical cancer is preventable, and the chances for survival for invasive cancer are dismally low in LMIC's countries. We know the interventions needed for its prevention and elimination, and we should invest in research and prevention. And that these interventions are not just effective, they are cost effective, and they can contribute to social and economic development. Again, I want to acknowledge the contribution of my mentors and collaborators. One of them, again, Supriya Lifang. Rob Murphy has been my long-term trainer in Northwestern for the past 13 years. And Stefan, a lot of you will know him. So these other grants, the D43, the U54, NCI funded cancer epigenetic projects, and then the K43. And of course, through the Northwestern Global Health Institute, we've also received donation to set up a community cervical cancer screening project targeting high-risk indigent population in Nigeria. So I'm happy to stop at this point and take questions and comments. Thank you.
Thank you so much, Jonah. That was wonderful. So we will move on to questions, and there are several questions in the chat box from Sandra San Miguel. So I think you can, since you were the first person in the box, you can go ahead and unmute and ask your questions directly. Keith, can she unmute her? Okay, good. Thank you.
Hi, good afternoon. Thank you for the opportunity. I have a lot of questions, and this is a very impressive research. Congratulations. I'll start from the beginning. I was wondering about the WHO's 90-70-90 goals and how these seem to be really high achieving for countries to be able to achieve. And I work with low and middle income countries in Latin America, and a lot of them are really at a loss because they don't have sufficient, for example, vaccines to be able to vaccinate their girls. And so what can we do to make sure that key leaders globally are more in tune as far as the needs of low and middle income countries, and be able to provide sufficient vaccines to the region as needed, especially now given the pandemic and how several governments are really struggling with their budget, and they've diverted a lot into COVID resources. So I know this is a huge question, but any insight that you can provide would be appreciated.
Yeah, thank you very much. That's a great question. And I just want to say that these countries, what we need to do as global health researchers and advocates is for us to generate data that we can use those data to do a lot of advocacy at the national government levels. Now, when we go to, from my own experience, when you go to speak statistics to government, they don't understand what p-value is. They don't understand all those percentages you're talking about. So you have to break down data, knowledge translation. You begin to let them understand the cost effectiveness of their action and the impact, the negative impact of their inaction. So once government have that understanding, then they can key into your interventions. Because I mean, the needs, the competition for healthcare needs globally, is so much. So what we need to do is really to advocate, and we have to advocate with good data and educating these policymakers. And once they have that understanding, then they'll be able to buy into your interventions. That is what I have to say. The government of Rwanda, let me say, they have been investing in national human papillomavirus vaccination for the past 10 years. And they are beginning to reap the evidence in that investment. So it's possible, even in lower middle income countries. We just have to generate the right political priorities and advocate for it, and we should be able to push the agenda forward. Thank you.
Thank you, Jonah. We have a couple other questions, and then if we have time, we'll come back to Sandra's questions. She had a couple other ones. So the next question comes from Rebecca Singer. So Rebecca, if you're there, you can go ahead and unmute.
Hi, thank you so much. This was really interesting presentation. I've done some work in cervical cancer prevention, specifically in low-income countries, and I was wondering if we used single visit approach, so trying to use visual inspection with acetic acid, and I know that you can do HPV testing, and just wondering if you've seen those approaches and how those are helping to increase uptake and increase acceptability, as well as increase access to sort of effective treatment by sort of combining those two into one, so screening and treating in the same day.
Yeah, that's a very great question, Rebecca. And the WHO is actually advocating now that we could do single visit, that is see and treat. And in lower middle income countries, they are pushing for VIA or VLI. And the advantage for single visit is that once you see an abnormality, you treat it that same day because of the barriers of effective follow-up in resource-limited settings. So we are trying to do that in Nigeria and in many other lower middle income countries. And it's a great point that we have to take into consideration as we push for cervical cancer elimination. Thank you.
All right, our next question is from Andrew Dykens. You can go ahead and unmute.
Thanks. Great. Yeah, thank you so much for this presentation. It was extraordinarily interesting. I really appreciate all of your work and the effort you put into this. My question is, the World Health Organization has recently added males as a secondary target group for HPV vaccination. However, Gavi doesn't currently fund vaccination for boys, and many low and middle income countries are having difficulty for various reasons advancing the conversation. So given that vaccinating both boys and girls against HPV will significantly advance the goal of cervical cancer elimination, I'm wondering, what is the status of the current conversation and or lessons learned for advancing this conversation in Nigeria if this conversation is taking place there?
Jonah, are you there? To us, it seems you're still muted.
Okay, yeah, I said, Andrew, I missed a little bit of your question. So maybe if you can come again.
Absolutely, yeah. Basically, the question is just focused on the recommendation for for males for HPV vaccination as a secondary target group by the World Health Organization. Gavi's not funding it, and advancing the conversation in many low middle income countries is difficult for various reasons. So I was just wondering about what the status of this conversation is in Nigeria, if this conversation is taking place, and potentially what are the lessons that are being learned there?
Yeah, in Nigeria, we don't have a national HPV program. We are still trying to discuss the possibility of starting it. So to just answer your question, we are making such conversation, but we're still far from it. Even the young girls are not getting immunized. So the young boys, we've not yet gotten there. But we're discussing such possibilities at the Federal Minister of Health.
Okay, thank you. And we have just another comment related to cost from Don Ziegler.
Supriya, Dr.
Yeah.
Musa, I know you need to leave in a few minutes. Is it okay if I drop your email in the chat so if people do have more
Supriya,
questions?
I'll have to leave now.
They can reach you. Okay.
If there are questions, please just email me. I have to pull out for another meeting.
All right. Well, thank you so much, Dr. Musa, and everyone for coming today. We'd keep you with us for much longer if we could. This has been a great presentation and lecture. Thank you to the audience for your attendance, and I hope that you do please follow up with Dr. Musa for the remainder of these questions, because there's some really great questions in the chat box. So thank you so much for your attention and everyone's time today.
Yes, and I did just put Dr. Musa's email in the chat, but if you don't get it by any chance, please email me, Supriya, or Allison. Thank you, everyone.
Thanks, everyone.